Welcome back. Let's just dive right in, shall we? Today we're tackling part 53 of our Masterclass Explainer, and we are demystifying the highly specific and, let's be honest, sometimes really confusing world of Nursing Facility Evaluation and Management, or EM codes. If you've ever second-guessed which code to use when a patient transitions from skilled to standard care, or how on earth to split a visit between a physician and a nurse practitioner, well, you're in the exact right place. Here's our roadmap for today's explainer. We're going to cover the facility framework, initial care, subsequent visits, discharge and assessments, and finally wrap up with physician versus NPP rules. Kicking things off with Section 1, the Nursing Facility Framework. So we absolutely have to lay the foundation first and clearly define the exact healthcare setting we're coding for, because as we all know, context is literally everything in medical coding. CPT groups these facilities in a really interesting way. Nursing Facility Services is actually a broad umbrella. It includes skilled nursing facilities, or SNFs, standard nursing facilities, and intermediate care facilities. Now, here is a crucial CPT guideline you have to remember. Whether the patient is in a skilled facility or standard one, a transition between these levels of care during a single stay doesn't constitute a new admission. Nope, it's all considered the same continuous stay for coding purposes. And because it's viewed as a single stay, this entire environment is governed by one unified block of codes. We are looking exclusively at the range from 99304 to 99318. This specific code family tracks the patient's entire cognitive care journey, right from the day they're admitted, straight through their daily management, all the way to discharge. Moving on to Section 2, Initial Nursing Facility Care. Let's look at how this builds. What exactly happens, and how do we bill when a patient is first admitted? Pay close attention to these thresholds derived straight from the latest CPT guidelines. For initial care, you've got two choices for code selection: medical decision-making, or MDM, or the total time spent on the date of the encounter. If you choose time, you've got to hit those strict thresholds. Code 99304 requires 25 minutes for straightforward or low MDM. 99305 requires 35 minutes for moderate MDM. And notice that 99306 strictly requires 45 minutes to meet the threshold for high complexity. That overrides any outdated assumptions you might still have memorized from older guidelines, so keep that in mind. Now, there is a massive compliance role attached to these initial codes. The initial comprehensive nursing facility evaluation and the creation of the patient's care plan absolutely cannot be delegated. By law and CPT guidelines, this crucial first step must be performed by the principal physician. It sets the baseline for the patient's entire stay, so no cutting corners here. Which brings us to Section 3, Subsequent Nursing Facility Visits. All right, so the admission is officially on the books. What's next? A patient in a nursing facility requires ongoing monitoring, daily management, and constant adjustments to their care plan. So how exactly do we capture all that cognitive work for the daily follow-ups? Well, that relies entirely on the subsequent visit code family. This brilliantly illustrates the subsequent care hierarchy. Just like with initial care, you're selecting these based on either MDM or total time. 99307 is your straightforward 10-minute code. 99308 is for low complexity, and that strictly requires 15 minutes. 99309 takes 30 minutes for moderate complexity, and then 99310 tops out at 45 minutes for highly complex daily management. The rule of thumb? Choose one method, either MDM or time, and make sure you can defend it in your documentation. You also really need to know that these subsequent codes aren't just for acute problems. They are the exact tools you'll use to report the routine mandated encounter intervals required under the CMS conditions of participation. Facilities have strict rules on how often a resident actually must be seen by a provider, and these are the codes that ensure those mandatory check-ins are properly billed and documented. Let's dive into Section 4, Discharge and Annual Assessments. Eventually, the patient is going to leave the facility, or they might become a long-term resident. Both of these scenarios require entirely different coding rules. Let's look at discharge management first. Unlike the initial and subsequent codes that rely on MDM or time, discharge codes are based exclusively on time. It's beautifully simple, really. It's split into just two codes. CPT 99315 is used if the final face-to-face encounter, the discussion with caregivers, and the preparation of discharge records took 30 minutes or less. But if that total time on the date of the encounter exceeded 30 minutes, you just bump that right up to CPT 99316. But what if the patient isn't discharged and they become a long-term resident? Rounding out this specific block is CPT 99318. This code is specifically and strictly utilized for the legally required annual assessment of a nursing facility patient. It's a highly specific code meant for a highly specific regulatory requirement. Nothing more, nothing less. And our final part today, Section 5, Physician versus NPP Rules. Okay, here is where it gets tricky and frankly where auditors tend to look the closest. Who is actually allowed to bill for these specific services? Care in a facility is rarely a solo act, right? It's frequently a team effort between a primary physician and a non-physician practitioner, or NPP, like a nurse practitioner or a PA. When they both contribute to an EM visit in a facility setting, it's called a split or shared visit. To bill a split or shared visit, both the physician and the NPP must be in the exact same practice group. That's a hard rule. Now, if your code selection is based on time, the shared visit is billed under the provider who spends more than 50% of the total time. You also have to append modifier FS to the claim to flag it as a shared visit. And, crucially, both team members must thoroughly document their individual contributions in the medical record. I can't stress this enough. Without documentation from both of them, you absolutely cannot bill it as shared. But NPPs have specific delegation limits in this setting. While they can handle a lot of the daily follow-ups and subsequent visits, remember our golden rule from earlier. The initial, comprehensive admission in a skilled facility level of care cannot be delegated. That firmly belongs to the physician. However, if a medically necessary assessment is required before the physician can actually get there for that initial visit, the NPP can perform it. They just have to bill it using the subsequent care codes, not the initial ones. And as always, make sure you verify your specific state laws because scope of practice can definitely vary. So why does all this granularity actually matter? Well, because as our sources state, accurate EM coding ensures proper reimbursement for your provider's time and cognitive skill. Ultimately, mastering these highly specific facility rules ensures your practice is audit-ready and that your coding accurately reflects the true intensity of the patient care being provided. When you align your documentation with the CPT hierarchy, you protect your revenue and you protect your practice. So win-win. And that brings us to the end of our deep dive into nursing facility E&M codes. I really hope this explainer helps you navigate the coding manual with a lot more clarity. Master the guidelines and you will code with confidence. But as CMS regulations continue to shift every single year, ask yourself, is your practice's documentation truly detailed enough to survive a split visit audit tomorrow? Think about it. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.